We are. Please proceed.
So thanks for the opportunity to share these reflections with you on the adaptations we made for the COVID-19 response in the Western Cape of South Africa, which we thought was a useful lens on our nascent attempts to build out a functional health information exchange. So to give some context, the province where I work has a population of 7 million people, and these run charts give you a sense of the burden of disease, and a lot of the information systems development we've done has been focused on developing services for HIV and TB, and you can see these very tall purple run lines affecting people quite early, so lots of years of life lost. This is 2009, and you can see still a huge burden of injury and trauma have overtaken in men specifically. HIV and TB is still by a long way the leading cause of premature mortality in women. And new infectious diseases have been consuming health systems globally. And we wondered when we started how it was going to affect our context. And compared to richer countries, we expected to have a lower burden because our age structure is so much younger, and we expected to see mortality being 3 to 4 times less than in Europe and North America. However, we weren't sure whether our infection fatality ratios or our morbidity would be higher given this very high burden of HIV and TB I just showed you. And we also weren't sure whether whether we'd be able to shield ourselves from infection in the same way as was possible in countries that were able to lock down, given the poverty and high density living circumstances of large parts of the population. So there were a lot of unknowns. This is how it's played out. We had quite a fulminant first wave peaking in around mid-year. Over here you can see the grey lines being our cases, and you can see that we're well into a second wave now. The yellow being the test positivity, tracking the cases, the blue being our hospitalization, and this has continued to go up this week, so it's almost close to where it was in the middle of the year. Oxygen consumption in hospitals, which is surprisingly a very useful marker of burden, and the red being the mortality. Using mortality as a benchmark, when I did this graph a couple of months ago, the Western Cape was actually right in 4th position after our first wave. And this demonstrates that although Africa as a whole has recorded very low morbidity and mortality, South Africa, looking at excess deaths in particular, has actually had a very pervasive epidemic. And even now, with countries being ahead of us in the second wave, we would be quite high up on the league charts in terms of mortality if we use our recorded deaths, which we know are quite substantially underestimate mortality in our setting in particular, and would be a lot higher if we relied on our excess mortality. And that sense of a very pervasive epidemic has been borne out by serology. So if we look at just after our peak, we had 40% of a biased sentinel population where we used residual specimens from antenatal care and patients getting annual viral load assessments. And that a little bit later had gone up to 45%. So a very high proportion in an admittedly biased population having been infected. Moving to the digital health context, the province where I work has had a unique identifier in place in progressive development or implementation for about 20 years, covering all 52 hospitals and 300 clinics. It's far from perfect, but it definitely is an enabler for linking data together. And just linking administrative systems, the hospitals, the laboratory and pharmacy systems, the disease registers such as the HIV and TB registers, mortality data when we've had it available, and quite a few other systems. Putting it together has tremendous utility. and sometimes we're just answering very simple questions, but we're having to do quite a lot of legwork to make sense of data that are quite disparate, not very well curated, but nevertheless can be incredibly useful. And in terms of what's in here, people often talk about the different technologies. Our learning, and I'm going to reflect on this in terms of COVID, has been that overwhelmingly the major investment and asset in this grey block in the middle is the people. So we have quite a strong sense it wouldn't really matter what technology platform we were working with. Having a cadre of data literate people who can work with large volumes of personal health data was the key enabler to help us to adapt to COVID when we needed to. We have about 8.5 million patients in the public sector who have been active in the last decade, and we're bringing in up to 1 million rows of attribute data every day. The first aspect is bringing the data in, and it's very straightforward coding in terms of person, time, person, place, and date, time, and we try to normalize, link all data to standard coding systems where we can, which isn't always the case. And the bit where we feel we add a lot of value is this beneficiation step, where we infer health conditions from a range of different what we call evidences, and we do it in a probabilistic way, so we can tune in and detune based on the use case, and make meaning of what are mostly administrative data with some clinical coding, and often that coding is not entirely reliable. So to give you a sense of that inference approach, so the types of data sources, this is a maternal health example. In rich countries, disease coding or from insurance claims or clinician coding would be the mainstay. We rely a lot on pathology. We're very lucky to have a single pathology service that curates all of their data centrally and provides it back to us. Drugs dispensed, location of services, which ward somebody went to in a hospital, which outpatient service, and community health worker or frontline worker digital health systems. Putting it all together, we grade evidence for a health condition into 4 grades at the moment, although this is an inference approach we want to sophisticate a lot more. And we stitch it together into a summative strength of evidence for a health condition. And we call that an episode. And then we roll and we persist the strength of evidence for every data point as far as we can into the episode. And then we add attribute data such as comorbidities, whether patients started treatment, how well they did on treatment. And we call that a cascade, which is essentially a virtual cohort. And this is quite well described in the publication if anyone wants to explore it further. And then that cascade becomes the building block of a lot of actionable items. So we can fire off alerts as people are added to the cascade. We can build our management reports, and we can also provide a clinical viewing platform for clinical care. This is just a very quick screenshot of the graphical viewer. For a patient who's had TB diagnosed very close to an HIV diagnosis back in 2009, did very well. This is a CD4 count coming up in red, viral load being suppressed, and then had a gap in treatment. CD4 count plummeted, returned to care, another gap in treatment, CD4 count plummeted further with viral load going up, and finally put on second line, and sadly quite soon after being on second line, another gap in treatment, and return to care with a CD4 count rock bottom. So moving on to the responding to COVID-19. So the readiness to act is one of the key learnings, and that's the people in the grey block I mentioned earlier. And listening to someone from Singapore talking about their response at a recent conference, they say you build these systems in the time of peace, not the time of war. And we really felt that having people who knew the technology available to them, imperfect as it was, and were able to very rapidly adapt, is a much stronger position to be in than trying to onboard new system on top of very fragile infrastructure, especially with context like COVID, where everybody's working remotely, and the circumstances are much more complicated and challenging. The second being having consolidated data available, so that one can provide the best possible information to support the response, both in terms of management response and case management. And then having near real-time data, so for outbreak response, being able to respond in time to contact tracing soon enough to make a difference. And then having real-time or near real-time comorbidity data, so that we can look at some of the epidemiological questions. And remember, I mentioned that there was this big unknown about how the burden of HIV and TB would be contributing to potentially higher morbidity and mortality in our setting, and then being able to share data for modelers and third parties. So the adaptations that we made in terms of the readiness to act were really following the same patterns that we're already doing for other data sources. So we were already bringing 700,000 rows of laboratory data in every day. And then we had to add 1, 2, 3, 4, 5, 6, 7, 8 new laboratory data sources from a variety of private laboratories. So a big difference for us was having to bring on private sector data, because there's mandatory reporting from the private sector to the government health services for notifiable medical conditions. The second area being moving from daily case builds to every 5 to 30 minutes, so that we could update throughout the day, which really was a change to the patterning of the entire system. Being able to register, so we were using the unique identifier from other patient registration systems, and suddenly we had to register patients from the private sector directly on our system, so adding patient registration, creating the ability to access the system securely on the public internet, so using cloud-based authentication, which luckily was already in place, and adding a Power BI premium node so that we could provide rapid web-based reporting. Adding geolocation so that the cases could be located for the outbreak response. With all of the extra activity, creating a high availability database environment, integrating with bespoke forms that were being spun out by our colleagues for data collection. And one of the challenges was measuring infections in healthcare workers, and we were able to link the payment, the salary database to the system, and automatically determine when health workers were becoming infected, and we could provide quite robust data on that very quickly. We added 2,000 users in the space of a very short time to enable the outbreak teams to be able to use the system for the outbreak response. The experience in the outbreak response was mixed. We built over time what we thought was a very flexible contact tracing and management system, but what we found is that for many users, there was just far greater affinity with using tools that they were more familiar with, and the system was largely used for deriving cases for further management rather than for managing the workflow of contact tracing in many instances. In terms of reporting, we produced a comprehensive set of reports covering a whole lot of different use cases that became the mainstay of reporting for everyone from politicians down to clinic health workers. In terms of epidemiological analyses, we were able to derive a virtual cohort of all patients who had attended the public sector in the last 3 years. We didn't know, we didn't want to use cases as our cohort because we knew that it was very biased as to who was getting tested. It was very much symptom driven. At certain times, our testing capacity was completely overwhelmed. So using a population denominator was the best way of determining the overall impact, combining the infections and morbidity and mortality or severity. And what we were able to show, looking on this at the hazard ratios, and these are on a log scale, is that we saw very similar patterns to rich countries, with men being at higher risk of severe disease, older people, diabetics. In fact, our hazard ratios for diabetes were higher, and we hypothesized that was because of the very poor control for many of our diabetics. And a number of other comorbidities. And for HIV, there was definitely a signal, but it was modest. It was lower than what we saw for younger ages, as well as what we saw for diabetes, and it was just over 2. And that is, we've actually looked at this subsequently after this publication came out on a much larger data set, and that hazard ratio of 2 has persisted. And then we were able to share data with the public and with modelers and with various other third parties. We had a public-facing dashboard from very early on. It may not seem like a lot when many health jurisdictions have similar tools, but in our context, it's the only live Department of Health managed dashboard. It's had 1.5 million visits and has won 2 technology awards. And we were also able to provide quite granular data to modelers, especially on health service utilization. So the modelers were really at sea when they started out in terms of local parameterization, and started with expert opinions on what the hospital utilization would be for patients with different severity of disease. And within a couple of weeks, we were able to provide very robust hospitalization data that allowed them to refine the models very, very quickly. And with that, I thank the organizers once more. I thank my colleagues from the data center, from the various organizations that have worked with us on the project. Thank you very much.